So first, I'm going to start with a bit of history and a big picture look at the strategy, the harm reduction strategy. In January of 2021, the Board of Supervisors removed a previous ban on syringe services in the unincorporated areas and directed the Health and Human Services Agency to create a harm reduction strategy for the county. This plan is based on multidisciplinary evidence and has 4 strategic domains, which are shown here on the slide, and I'll describe these briefly. So first, cross-sectoral convening. I think we're all aware, since we're part of this group, that reducing harms associated with substance use really needs to be interdisciplinary and needs to be a collaborative undertaking. And part of that needs to involve cross-sectoral convenings. And this includes with health networks, community-based organizations, family and community voices in San Diego, and this is just to name a few. So next domain, integration. And here we're talking about integration across behavioral health and physical health as a key component of addressing the well-being of people at risk of harms. Next is housing. We know that substance use and homelessness often overlap, with homelessness exacerbating the harmful effects of drug use and vice versa. And we know that being on the street increases all health risks, including those related to substance use. So housing, therefore, is a key pillar of our strategy. And then workforce. Finally, we're prioritizing developing a workforce that's trained and skilled in harm reduction. And I'll end this slide by saying that overall, an important aim of advancing this work is that it will really help to ensure that we have the same infrastructure investments for behavioral health as we've had traditionally for medical or infectious illness. So now I'm going to take a step back and talk a little bit about why a harm reduction approach is important. So it's estimated that 90% of those with a diagnosable substance use disorder never access treatment. And this is based on national data. So due in part to this, we see substantially disproportionate physical illness among those with histories of substance use. And people with a substance use disorder are 3 times more likely to end up in the emergency department and 5 times more likely to be hospitalized than those without a substance use disorder. So you might be wondering, why aren't people accessing care? The reasons are complex, but those who have studied this issue are certain that part of the explanation lies in that our health systems and care services that are meant to treat addiction haven't sufficiently embraced a harm reduction approach. And at the population level, expecting people with a substance use disorder to begin treatment by making a commitment to sobriety just hasn't worked in the past. But conversely, a harm reduction approach establishes that a first priority is keeping people alive and helping them to get well. And that on this path of increased wellness are opportunities to treat addiction. And we already know that this approach works. So there's over 30 years of evidence from around the world that's shown that harm reduction approaches reduce the spread of Hep C and HIV. They reduce overdose deaths. They lead to greater engagement with treatment, and they do not lead to increases in substance misuse. So what is harm reduction? So that we're all on the same page about what harm reduction is, I'm going to start by defining it. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It's also a movement for social justice built on a belief in and a respect for the rights of people who use drugs. It incorporates a spectrum of strategies from safer use to managed use to abstinence. And it's really focused on meeting people who use drugs where they're at, addressing conditions of use along with the use itself. So here I'm displaying some of the guiding principles of our county strategy. And those include human rights and dignity, diversity and social inclusivity, health and well-being promotion, partnership and collaborations, partnership, in other words, nothing about us without us, and accountability and improvement. So I think one of the important concepts to keep in mind is substance use as a continuum, instead of something that is linear or binary. So a person can move back and forth within this continuum, and it's not just a one-way path. So people can be at different points for different substances. And harms can occur at any point and should be addressed regardless of where the person is on the continuum. So an important concept to keep in mind. Another important framework when thinking about harm reduction work is to consider the concept of drug set and setting. Providers, and I'll speak for the provider community, often jump to the drug part of the model and want to focus immediately on addressing potential harms there. But it's also important to assess with your patient what they want to prioritize, and maybe it's their set or other health care or mental health concerns, or food access, for example. Or maybe it's setting, having a safe place to stay and developing support networks before addressing drug use. So to sum up this concept, harm reduction looks at where improvements can be made across drug set and setting. And I'll go into more detail here. So here are some concrete examples of what I mean when I say drug set and setting. So first, the drug. What is the drug itself? How does it, what it does, and how potent is it? What is it cut with? How is it used? For example, smoked or snorted, etc. And whether it's legal or illegal. And then set, meaning the person's unique personality, the person's physical or mental health or emotional state, cultural identity, and the person's expectation of the drug or motivation for using it. And finally, setting, the stresses in a person's life, support in someone's life, with whom and where the person uses, alone or with someone else, and social and cultural attitudes towards the drug. So again, these are all important things to take into consideration when using a harm reduction approach. So where does this leave us exactly? So we are moving away from the things on the left-hand side of the slide, which are stigmatizing language, thinking of substance use as a moral failing, having abstinence as the only goal, working in silos, the concept of having failed the program, having care contingent on treatment readiness, and an overemphasis on universal need for detox. And what are we moving towards? Those are the items on the right-hand side of the slide. We are moving towards person-centered language, viewing substance use disorder as a chronic health condition, using a harm reduction approach, creating an integrated system of care, expecting lapses and relapses as part of the course of the condition, and the importance of low barrier care centered on the client's express goals, and quick start and low barrier MAT or medication assisted treatment, such as methadone or buprenorphine. So now back to the 4 domains. So each domain or focus area has immediate, intermediate, and long-term tactics, and I'll mostly be talking about the immediate and intermediate tactics here. So first, a focus on cross-sectoral convening. So San Diego has really been a national leader in addressing substance use through an interdisciplinary approach. And most of you who are in this audience likely already know this, but for those of you who are new, in 1996, decades before the recent opioid epidemic gave rise to community collaborations across the country, the Meth Strike Force was established here, and a little over 10 years later, the county established PDATF. And so although these predated my move to San Diego about a year ago, I fully appreciate that these have been life-saving institutions and the settings for some of the county's most important responses to drug-related harms. So these entities, the MSF and PDATF, as I think you are mostly aware, will be unified formally into a single task force. And this will make a structure that is really more aligned with the ever-shifting nature of substance use in our communities, where polysubstance use is common and where different types of substance use epidemics are constantly overlapping. So the new name of this single task force is still TBD, but I've put as a placeholder here, Substance Use Harm Reduction Task Force. I'll say that a key feature of this newly established task force will be evenly shared governance between public health and public safety, so that we can really leverage all of our resources and data in a coordinated way. All right, so on to healthcare integration. So the intent here is really to enable the breakdown of long-standing silos between care for addiction or specialty treatment services and mainstream healthcare. So a very important component of our integration efforts is increasing access to naloxone. As most of you likely know, naloxone is an emergency medication that reverses the effect of an opioid overdose. And in July 2021, the County of San Diego launched its naloxone distribution program. And to date, we've distributed over 10,000 naloxone kits. And to expand these efforts, as of July 2022, the county contracted with the Harm Reduction Coalition of San Diego with the goal of saturating the community with naloxone and specifically distributing 33,000 naloxone kits by June 30th, 2023. So this expansion effort includes targeted outreach and training efforts, partnerships with community organizations, and implementation of naloxone vending machines that will be placed across the county. So next, I'm going to talk about the Syringe Service Program, or SSP, action plan. So as part of the county's harm reduction strategy, Public Health Services, or PHS, has been leading the county's Syringe Service Program action plan. And this plan has 4 components that are shown here on the slide on the left-hand side. And I'm going to share some notable progress in this work. So first, partnering with the San Diego State University Research Foundation Institute of Public Health to conduct the Community Readiness Assessment. And the goals of the Community Readiness Assessment are shown here on the right-hand side of the slide. And those were to gather insights into resident knowledge about SSPs, to identify organizations that are supportive of syringe service programs, or SSPs, and to understand community concerns and objections. So the findings of the CRA, or Community Readiness Assessment, are helping public health services to determine the geographic locations for future SSPs, to better understand ongoing challenges and to identify strategies to address community concerns, and also to develop best practices around SSPs. So the CRA will be available to the public by the end of this month. So I'll make sure that Marla gets a copy and can send it out to you all. So regarding the next dot point on the left, convening the county enterprise around planning and implementation. So Public Health Services established an internal working group last summer with representatives from various county entities, including Behavioral Health Services and the Public Safety Group, as well as the State California Department of Health and local harm reduction providers. And this was really to develop and implement the county's SSP program. The work group focused on program goals and also a program operating plan. And finally, regarding implementation and evaluation. So Public Health Services used the information from the internal working group, from the CRA, and the latest county data on overdose to help determine the locations for county SSP programs. Now, while these locations have not been finalized yet, services will likely be provided in various HHSA regions, including North Central, North Coastal, North Inland, East and South regions. In terms of SSP program evaluation, PHS is planning to release an RFQ to develop a monitoring and evaluation plan. And I'll end by saying that the goal is to launch the SSPs by winter of 2022. So now moving on to the housing domain. The Community Harm Reduction Team, or CHART, and Harm Reduction Interim Shelter is a joint effort between Behavioral Health Services and the City of San Diego Housing Commission. CHARTs are multidisciplinary teams that offer low barrier harm reduction services, connections to behavioral health and bridge housing. So in November 2021, CHART began outreach and engagement to individuals experiencing homelessness in the East Village, City of San Diego, and Midway areas. And this is specifically for individuals who have chronic substance use conditions and are hard to engage in services. Family Health Centers of San Diego is the provider for outreach engagement, care coordination for the individuals enrolled in CHART. Services include connection to primary care, behavioral health services, medication management, medication-assisted treatment, and syringe services. So upon initial engagement by CHART, individuals are welcome to the Harm Reduction Interim Shelter with day-to-day operations provided by the Alpha Project. And this offers 24-hour staffing to support up to 44 beds. And while clients are in interim housing, CHART provides ongoing case management services and connections to an array of supportive services. And services are intended to be a short-term solution to assist individuals in transitioning to the most appropriate longer-term or permanent housing available within the community. So next, workforce. To ensure that our harm reduction efforts are successful, we definitely need to actively support our behavioral health workforce. So recently, we in BHS have invested particularly in developing peer support services within the drug Medi-Cal organized delivery system. And those are provided by those with lived experience who have points of common reference and identity between themselves and service recipients. So specifically, substance use disorder contracts have recently been enhanced to include peer support specialists, and county contracts now include language regarding required harm reduction trainings for all contracted staff. And in addition, the Workforce Conference. So the San Diego Workforce Partnership assessed challenges facing behavioral health workforce in San Diego County, as well as proposed solutions. And a report was presented recently in August 2022 at the Behavioral Health Workforce Symposium. And some of the highlights of this included showing that the San Diego region has a significant shortage of behavioral health workers, and that possible solutions include a workforce training fund, regional training centers, and legislation that could support behavioral health workforce. So looking ahead to longer-term strategies for these domains, in terms of cross-sectoral convening, this includes developing an integrated, unified regional governance structure for harm reduction, housing, establishing parity in funding for substance use housing resources. In the workforce domain, expanding peer specialist workforce trained in employing harm reduction strategies within the county system of care. And finally, with healthcare integration, pursuing policy solutions to integrate mental health with substance use programs. So I will end my presentation there. Thank you very much.
Hi, everybody. Good morning. I am Sandy Tutt, Public Health Analyst with the CDC Foundation. I am one of the two members of the team for our overdose response strategy, and I'm going to go over overdose response coordination among public health and public safety. So just a federal acknowledgement about our funding. So the overdose response strategy, just to quickly give you a background, the mission of the ORS is to help communities reduce fatal and non-fatal overdoses by connecting public health and public safety agencies and sharing information and supporting evidence-based strategies. The ORS allows us to collaborate across public health and public safety sectors. We share by sharing data, insights, and trends. There are 60 teams, 60 ORS teams across the nation, and we are also communicating and helping each other and trying to fill those gaps in our information and data. So for this presentation, we'll review San Diego drug seizure trends. I'll let my partner, Alex de Armas, introduce himself for his on his slide where he'll discuss what we're seeing in San Diego. We're also going to explain why partnerships between public health and public safety systems are important, and also discuss just practical strategies and lessons learned for cross-sector collaboration, and also just present some free resources and toolkits that are available for you to guide implementation and evaluation of programming. So I'm going to pass it on to my partner, Alex de Armas, who'll introduce himself and also talk about what we're seeing in San Diego regarding our drug trends.
Good morning, everyone. I'm Alex de Armas, one of your two ORS or National Overdose Response Strategy representatives in San Diego and Imperial County. I work as a two-person ORS team with my partner, Sandy, who you just met. Sandy represents the CDC and the public health sector, while I, on the other hand, represent ONDCP and the high intensity drug trafficking area, or the HTUT program, the public safety side of the ORS. Like Sandy said, the ORS is a collaborative initiative supporting efforts to integrate public health and public safety to bring down the death toll and the prevalence overall of drug overdose across the nation. By title, I am a drug intelligence officer for the San Diego and Imperial ORS, although I much prefer the term public safety coordinator. A few relevant points in my background: I served 35 years as a police officer, San Diego police officer, investigator, and supervisor. Much of that time I spent in drug-related investigation and in criminal intelligence focused on transnational drug trafficking. Also relevant, maybe even more relevant, for several years I supervised the San Diego Police Child Abuse Unit, where I became immersed in interdisciplinary work. And the reason I bring that up, obviously, is the collaboration across disciplines is critical in addressing child abuse and drug endangered children cases effectively, and it is equally critical, I believe, here addressing the overdose epidemic if we aim to be effective. Okay, so let me move into a survey of San Diego drug seizure trends, and then we'll move into also consumption and supply. The next two slides show a graph comparison of U.S. Customs and Border Protection seizures of fentanyl, heroin, cocaine, and methamphetamine in multi-kilogram quantities from 2019 to 2022. First of all, I just want to point out, it's important to note that this only gives us an idea of the illicit products seized at the ports of entry by CBP in bulk. It doesn't account for other seizures by other agencies across the country, but it does give us a baseline. Here, the main points from this graph that you have here, the fentanyl and heroin graph. First of all, fentanyl continues to show recurring spikes, most notable here in late 2021, and again, a very pronounced spike in the summer of 2022. Next slide, please. Sandy, next slide. Thank you. So in this slide, we're looking at methamphetamine here, and looking at the seizure weights and quantities of methamphetamine. It is pretty clear that methamphetamine is still king in San Diego County. However, it's the lethality of fentanyl that makes it inherently more problematic, even at lesser quantities. And we know now that the fentanyl is being found sometimes inadvertently mixed into loads of methamphetamine as well. So that also becomes problematic when users believe that they're going to be using meth and they get a hit of fentanyl in their meth. Again, these port seizures do not tell the whole story and do not put the story into context. What happens with the drugs that do get through? Where do they go and how are they consumed? So I'm just going to stay on the slide for a little while and answer some of these questions. The San Diego region is unique. San Diego doesn't import fentanyl or meth or any illicit substance strictly for its own consumption. San Diego's importation feeds the rest of the country. Illicit substances that make it through our ports sit in the many, many warehouses and stash pads throughout San Diego County. Hundreds of pounds of meth and fentanyl stashed in houses, apartments, and commercial buildings in our county, just waiting to be moved to LA, Vegas, Chicago, New England, where it's distributed by hundreds of mid-level drug trafficking organizations and street gangs to users entrenched in opiate use culture. We know this brings traffickers exponential profits. Moving it increases the profits. But what about San Diego? Obviously, a significant amount of fentanyl does land in our communities, as evidenced by people dying at record numbers. What are San Diego's consumption trends, and how are they fed by our own local suppliers? I'm going to rely on a resource here. The DEA Overdose Response Team investigates fentanyl overdose deaths throughout San Diego. You all may know the Overdose Response Team, previously known as NTF, or Narcotic Task Force Team 10, and sometimes we use that term as well. It's now known as the DEA Overdose Response Team. This is a DEA-based HTUT initiative made up of federal, state, and local law enforcement investigators who respond to death scenes and identify dealers aiming to intercept lethal fentanyl supplies and prevent the next death. The following information comes directly from them, from their daily observation and from DEA and HTUT statistics. First of all, investigators estimate 85% or more overdose deaths in San Diego involve powder fentanyl. Smoking fentanyl powder, usually off of aluminum foil, which is a common methodology, is the most common method of ingestion identified by investigators at death scenes. From 2018 to 2022, the majority of overdose deaths in San Diego involved pills, the counterfeit M30s, commonly known as blues. After 2020, investigators saw an overwhelming shift from using pills to smoking powder fentanyl, a disturbing trend for sure. Smoking powder is more potent, and for users who've developed a tolerance, it's more efficient and cost-effective, thus a more likely choice. DEA Special Agent Jackie Garcia with the Overdose Response Team provided the following numbers to illustrate this further. In October 2022, just last month, the Overdose Response Team went to 14 overdose death callouts in the city of San Diego. Of those 14 deaths, 2 were from counterfeit M30 pills. 1 was from injection via syringe, and 11 were from smoking powder fentanyl. Okay, so let me move on to the supply. Where did the decedents get their fentanyl? Special Agent Garcia and her team regularly track lethal supplies back to street level dealers who distribute 1 or 2 gram quantities, commonly ordered up as $100 worth, or that's the term they'll often use. Give me 100 to mean give me 1 or 2 grams, whatever that'll get them. They have been able to track the supply to the original dealers and sources of supply, and discovered that they're very often the same individuals smuggling the product from Mexico. Most common method of smuggling for these street level dealers is internal body carrier. And usually the product is brought over 1 to 2 ounces at a time. And Sandy, I will hand it back to you.
Thanks, Alex. So now, before we move forward, I want to make sure that we're on the same page about what we mean when we say public health and public safety. So public health includes behavioral health and health providers, health departments, harm reduction agencies, and death investigation systems. It also includes payer sources, insurance, and pharmacies. I'm going to let Alex talk about the public safety side and what that entails. And please keep in mind that this is not an exhaustive list of all possible partners. Oh, you're muted, Alex.
Okay, just real briefly, public safety obviously is going to include your court systems, prosecutors, judges, corrections, and extensions of that. But most importantly, I wanted to bring attention to the first responders, police, fire, emergency medical services, and also the investigators, which are a huge component of the public safety contribution to the ORS. Back to you, Sandy.
So this is just from research in the CDC about the importance of strong public health and public safety partnerships. Nationally, overdose from opioids is currently the #1 cause of death among individuals 18 to 45 years old, surpassing car accidents, suicides, and heart disease. And synthetic opioid accounts for the majority of overdose deaths. And only 11% of individuals who needed treatment received treatment in 2018. And criminal justice involvement is associated with higher risk of overdose. And overdose is the leading cause of death among formerly incarcerated individuals. And previous non-fatal overdoses strongly predict future fatal overdose. So the big takeaways here are that not everyone will access treatment for whatever reason, and whether they aren't ready or they couldn't get into treatment. And first responders and criminal justice systems end up being the first point of contact for a lot of people who use drugs. So this is just a continuum for opportunities for intervention. So on this slide, it presents a high-level view of some ideas for interventions for our public health partners that can take along with the criminal justice continuum. And please note, we don't need to make our public safety partners do more work. We should seek to use this where we should seek to see where people are using drugs within the continuum as a jumping out point for our public health partners to intervene. So you can see just from the chart that, law enforcement interaction, now we can screen for linkages to care, court system diversion, and so on and so forth. So for public safety involved linkages to care, there are a lot of different linkage to care models, such as pre-arrest diversion, re-entry when leaving incarceration, safe stations, and law enforcement-led post-overdose outreach. So these are just some evidence-based continuum of services that we can provide with the coordination with public health and public safety. So I want to also just discuss the quick response team models. So there are called post-overdose response, drug abuse response, like just many names for basically responding to what happens after an overdose, where a person overdoses and there's a team that goes out that's made out of law enforcement and EMS, mental health therapists, substance abuse counseling, and a peer mentor. And it's developed to encourage agencies to work together as opposed to agencies with similar interests working in parallel. So while these teams are popping up all over the country, there's almost no rigorous scientific studies on their efficacy, but as you do more, that's how you get more data. So this is a case example for a team in a rural Midwestern town. So this wouldn't be how it will work in San Diego, but just kind of giving a very simple flow chart of what would happen. So if the chief of police gets alerted to an overdose by dispatch or concerned citizen, identifying where that person is from and then contacting outreach and then providing care. So just a simple flow chart of how the linkage to care would work with the quick response team. So some promising practices. So this particular model, focuses on visiting people at their home, but some people don't have homes. We have that issue in San Diego with our homeless population. So place-based or community-based outreach is going to places where individuals may congregate in the community to offer services, and of course, minimizing the number of team members, using peer mentors, and really should be person-centered and non-coercive. So we're going to talk about some data-driven program implementation. So asking ourselves key questions on what we're trying to answer and the data sources that may help answer those questions. So this is really the data to action aspect. And for linkages to care programs, asking questions such as who is overdosing, who is in need of care, treatment, and support services, and how we're going to measure that effectiveness. So this is just a list of some ideas of data sources, again, not by any means an exhaustive list. And we also need to talk about data sharing and confidentiality, and obviously data needs to be protected, and collaborating agencies will have to come up with agreements on who needs to have case level information and try to figure out how we can, protect the PHI and also be able to have that data inform our work and have that be useful. So the next part that Alex and I are taking on is also getting our EMS agencies and law enforcement agencies reporting to ODMAP, which is the Overdose Detection Mapping Application Program developed by Washington Baltimore HIDA. So it provides near real-time suspected overdose surveillance. So these are all suspected. It just gives us a snapshot in real time of what's going on currently in our community. And it supports public health and public safety efforts to mobilize resources during a spike in any overdose event. So ODMAP allows agencies to set up alerts for whenever there's an anomaly for overdoses, and we're able to convene and talk about what's going on, and even maybe deploy our quick response teams in communities that are getting inundated with overdoses, and being able to get those resources out there in real time and be more proactive instead of reactive. And there is no protected health information collected in ODMAP. They only require 4 data points, which is the type of overdoses, the type of suspected overdose, whether it's fatal or non-fatal, whether naloxone was used, and just date and time. They don't collect addresses. They geocode it so that that little point of suspected overdose lands in the middle of the street. It would never land on a house, a house or a business. And it's the incident address. So we don't have the resident's address or anything like how we will get it with emergency department data. So this is really where this person overdosed. So really, somewhere, it will land somewhere in the middle of the street. So a little ODMAP update for San Diego. California EMS Authority has started reporting overdoses into ODMAP that is reported by the local EMS authority. So right now, the San Diego County EMS is working on having all the EMS agencies report to the local EMS authority so that the state can then report it to ODMAP. We're also working with certain agencies, law enforcement and EMS agencies, so that we can also help implement that API while the county EMS is working also on the bigger agencies like San Diego Fire. We know the processes takes time, so we're just trying to get as much as we can into ODMAP so that we can do something about it now as well. And so this is what ODMAP looks like right now. So the circles are non-suspected non-fatal overdoses, and the little diamonds are suspected fatal overdoses. So as you can see, for the city of San Diego, you only see the fatals because that is our post-overdose death response team filling in that manually in ODMAP. And the circles, the non-fatal overdoses are actually being reported by the California EMS Authority through the local EMS authorities reporting that data to them. And you can see we have a lot of gaps obviously missing, so that's what we're trying to do. But this is from January 2020 to September 15 right now. So we already have some data in there that we're trying to work with. So hopefully once ODMAP is more complete, we're able to set an accurate alert response and be able to see what's going on in our community, and not just by zip code level, where sometimes that's way too big, but this is very geographically specific so that we can actually target who we need to target. So this is the ODMAP and the spike response, just a little like flow chart of what would happen when there's an overdose alert. So I know in San Diego, we're also trying to, Dr. KATTAN is working on getting this overdose cluster response protocol ready. And we're hoping to use ODMAP as one of the data sources so that we're able to respond in the community in real time. So we're pretty much coming up on the end of our presentation. The next parts are just resources that are available if you do not know just the internet. If you wanted to learn more about public health and safety teams, our overdose response strategy project, evaluation, also definitely with any kind of guides to setting up programming, any medicated assistant treatment, the overdose spike response framework, and CSTE, the Council of State and Territorial Epidemiologists. They also have an overdose anomaly toolkit. So using that to try to figure out how to respond to an overdose anomaly in the community, and just free resources and toolkits for working with certain populations like rural and tailoring efforts to diverse groups, especially with tribal and urban Indian settings and health equity. And these are just the references for what was presented. And this is me and Alex's contact information. So if you have any more questions, please feel free to email us and be happy to talk to you about anything. Thank you.